Thank you. And so the second talk will be related to the pulmonary hypertension secondary to lung disease. And from our perspective, from the perspective of a respiratory physician, I can tell you that it's a very, very important topic, very important problem also, especially in certain chronic lung diseases like COPD, interstitial lung diseases. The relevance of pulmonary hypertension is huge in terms of prognosis and management. And often the problem is that on one side we are dealing with the lung problems, and when pH develops, then automatically the prognosis suddenly dips. So in this we have Dr. Murli Mohan from Bangalore to talk about the very important subject, and I'll invite him to start. Thank you.
So thank you, Professor Mohan. Thank you to the organizers for inviting me here to give this talk. It's a little inhibiting to be speaking to not just cardiologists, but pediatric cardiologists, but I'll do my best. I've been asked to talk on pulmonary hypertension, secondary to lung disease. And that's the center I work, the Narayan Hridayalaya and the Mazumdar Shaw Medical Center, a part of it. These are my conflict of interest statements. And also a caveat, I'm not a pediatric cardiologist, nor a pediatric pulmonologist, I'm an adult pulmonologist. So it was said quite nicely in this article from this year that the human pulmonary circulation is full of mysteries and surprises. And until the 1990s, this no man's land between cardiology and pulmonology was largely unexplored. So over the last 20 to 25 years, there's been an outburst of knowledge in this area and a huge improvement in patient outcomes. So what I plan on talking about is pulmonary hypertension and lung diseases, what's its pathogenesis, how relevant is it? How does one treat it? And when do we use pulmonary vasoactive medication? So we've already repeatedly heard this definition, but basically, if you look at group 3 pulmonary hypertension, it's usually grouped with a pre-capillary pulmonary hypertension, and specifically those associated with chronic lung disease or chronic hypoxia. And into this group, the overwhelming majority is obstructive lung diseases. But over time, we're seeing a lot more of restrictive lung diseases, those with a mixed obstructive restrictive pattern, but also hypoxia without lung disease, such as sleep disordered breathing, and of course, developmental lung disorders. So though the 6th symposium came out with pre-capillary pulmonary hypertension being seen in group 3, we'll show you later that a lot of what we're seeing in patients with chronic lung disease is actually due to group 2 disease. And of course, group 5 is interesting. For example, we looked at sarcoid and it would formally come into group 5. But if the pathology is predominantly from the lung, it would fall into group 3. If it's because of the because of the heart disease, it would be group 2. And with its direct vascular involvement, it would be group 1. So these days, the recommendation is to go with whatever is primarily causing the disease and not just lump it into multifactorial cause, but put it into the appropriate group with the major pathology so that we know what our focus of treatment should be. But it's very important to realize that pulmonary hypertension and lung disease carries the worst prognosis of all. So when compared with left heart disease, for example, or even with idiopathic pulmonary hypertension or pulmonary arterial hypertension, which we often thought of as having the worst prognosis, patients with pulmonary hypertension and lung disease really have a terrible prognosis. And this is true whether you're looking at one registry or the other. Those were from the Aspire and Spanish registries. And even within group 3 pulmonary hypertension, it's very important to know what is the exact underlying cause. For example, those with sleep disordered breathing seem to have better outcomes than those with COPD. And the worst outcome of all is with pulmonary hypertension in interstitial lung disease. And this is not surprising because pulmonary hypertension in interstitial lung disease is either due to extensive lung disease itself, or, for example, in systemic sclerosis, is associated with what predominantly behaves like a group 1 pulmonary hypertension with an overlapping element of lung disease. So these are patients who are often extremely hypoxic by the time they develop pulmonary hypertension. And by the time you are able to diagnose it, both the interstitial lung disease and the pulmonary hypertension are usually extremely advanced. But it's important to remember also that in group 3, pulmonary pressures are usually only mildly elevated, And the presence or absence of pulmonary hypertension is one of the strongest predictors of mortality in lung disease. And even those with moderate pulmonary hypertension should be investigated further. And the cutoffs that we use often in other forms of pulmonary hypertension should probably be reduced in pulmonary hypertension in group 3 patients. So we call it severe if the cardiac output is reduced, or if the mean pulmonary artery pressure is greater than 35. And I'll come back to this. So we recognize 3 groups: those with chronic lung disease without pulmonary hypertension, where the mean pulmonary artery pressure is less than 21 millimeters of mercury, or where the mean pulmonary artery pressure is between 21 and 24, and the pulmonary vascular resistance is less than 3 Wood units. Then you have those with pulmonary hypertension, where the mean pulmonary artery pressure is either more than 21 with a pulmonary vascular resistance which is elevated beyond 3 Wood units, or the mean pulmonary artery pressure is greater than 25. And this is very important because very often we do not do right heart caths in patients with lung disease, and we just rely on echocardiographic data. Finally, you have those with severe pulmonary hypertension, where the mean pulmonary artery pressure is 35 or more, or you have a mean pulmonary artery pressure the low cardiac index. This comes into the group with severe pulmonary hypertension associated with chronic lung disease. Having spoken about this, how common is pulmonary hypertension in lung disease? We know that COPD is one of the most frequent causes of group 3 pulmonary hypertension. And if you look at the global burden of disease data, COPD is one of the top 3 causes of morbidity, mortality, disability adjusted life years in all non-communicable diseases. And in India, we are number 2, secondary, second only to ischemic heart disease or coronary artery disease. And over 90% of patients with severe COPD have been estimated to have abnormally high pulmonary pressure. So these are very advanced stages of COPD, and practically all of them will have a high pulmonary pressure because practically all of them have been hypoxic for some time. But only 3 to 5% of these patients have severe PH as defined previously. This paper came from 2010, and we would probably relook at these numbers now. The mean pulmonary artery pressure, however, in COPD does not correlate with the severity of lung disease and seems to be more closely related to the pulmonary capillary wedge pressure. And it's only mildly elevated in the majority of these patients, as I said, but it's thought that the high pressures may be due to diastolic left ventricular dysfunction in advanced COPD, or comorbid heart disease causing systolic dysfunction, or the gas trapping that occurs in those with advanced COPD causing elevated intrathoracic pressures, and a whole cycle of physiological changes that stems from this. So what we really need to look at is that group who have so-called out of proportion pulmonary hypertension. And this was one of the early papers by one of the pioneers in this field, Shao and others. They looked at almost 1,000 patients with COPD and found that about 2.7% had severe pulmonary hypertension defined by a greater than 40 millimeters of mercury pressure. But in just 1.1%, less than half of this number, COPD was the only identifiable cause of PH. And when they looked closely at these patients, they didn't have very severe lung disease, but they were very severely hypoxemic, and they had a very low DLCO, suggesting that the pulmonary hypertension was the cause of idiopathic pulmonary hypertension, perhaps, which overlapped with COPD, was the cause of the pulmonary hypertension rather than the lung disease itself. But even mild PH is of prognostic relevance. And if you look at the 5-year survival rates, those with a mean pulmonary artery pressure of just greater than 25 had just a 36% 5-year survival. Whereas if it was less than 25, you had a 62% survival. And Weizenblum also showed earlier that you had a cutoff of more than 17 millimeters of mercury mean pulmonary artery pressure. Immediately, the mortality rate started rising. So the earlier cutoffs were probably more relevant, lower cutoffs, rather than what was used at the time of these studies, which went on from 1981. So we've learned a lot about this in the last 40 years, really, PH in group 3. And then most of these studies have used echocardiography, as I said earlier. And that's true also of patients with IPF, where the presence of pulmonary hypertension had a linear correlation with mortality. And this was in patients who also had right heart catheterization because they had the RHC before being listed for lung transplant. And as I said earlier, even in ILD, a cutoff of 17 millimeters of mercury was predictive of mortality. The same happens in sleep disordered breathing. A lot of patients these days we're diagnosing backwards. We recognize their pulmonary hypertension, go back and diagnose them with sleep disordered breathing. And very often this too is mild or moderate. So please don't ignore mild to moderate pulmonary hypertension, especially in patients with obstructive sleep apnea or other forms of sleep disordered breathing. Because when you have an overlap of OSA with OHS or an overlap of OSA with a second lung disease, such as the COPD-OSA overlap, or increasingly we're realizing the OSA asthma overlap, all these patients tend to have, because probably of the double whammy, a higher pulmonary pressure. And in this case, the severity of the OSA correlates with the severity of PH, but again, is often associated with post-capillary pulmonary hypertension, and therefore is probably secondary to left heart disease associated with the OSA rather than the hypoxia itself. However, there are patients who had a mean pulmonary artery pressure correlated directly with their BMI and negatively with their PaO2, suggesting that these were patients with not only OSA, but daytime high CO2 and low oxygen, suggesting that they had obesity hypoventilation syndrome also. We have very similar data. This is a paper we've just submitted, where 137 patients with a mean age of 61 years, we had almost 40% of patients with pulmonary hypertension. And when we use the recent cutoff of 20 millimeters of mercury, we got prevalences of more than 60% of PH in patients with ILD. A lot of these were in those with connective tissue disease, but also you had big numbers in NSIP, HP, and sarcoid. So what's the pathogenesis of PH and respiratory disease? Because this is what, as pulmonologists, we need to tackle. Very often it's just hypoxic pulmonary vasoconstriction, but also polycythemia and destruction of the pulmonary vascular bed. So the cross-sectional area of the pulmonary tree is, vascular tree is reduced. But also we recognize that there is endothelial dysfunction common to all cardiovascular and pulmonary diseases. And the role of genetic factors is increasingly becoming obvious. So it's hypoxia, but not only hypoxia. And you find that when you do, just like our last speaker, Dr. Bansal said, there's also changes in even mild to moderate disease, where there are intimal changes and medial changes very similar to idiopathic pulmonary hypertension in those with more severe disease. And perhaps in a majority of patients with COPD and OSA, left heart disease is the major contributor. So when do I suspect a patient with pulmonary disease has also pulmonary hypertension? Because dyspnea and fatigue are common symptoms to both. And we really should keep our eyes and ears open for pulmonary hypertension associated with the chronic lung disease. But the symptoms are more severe than we expect from the lung function data. Signs of right heart failure develop, indicating that the person has definitely developed cor pulmonale. And there is profound hypoxemia, hyperventilation, and a lower than expected DLCO for the lung disease, because that signals pulmonary hypertension. What do? We usually do only a 2D echo screening. We also do a BNP, but this lacks specificity, as you all know. And we never base the assessment of PAP on during an acute exacerbation of lung disease. We always wait for a stable state for at least a month. There are conditions where you will do a right heart cath, very similar to what Dr. Bansal just said. So I'll go on to the treatment aspect. So when you look at the problem, as we said, it often is chronic lung disease and hypoxia. So the cornerstone of treatment is treatment of the hypoxia. And we use data from the MRC and NOT trials, which were done in COPD, and use oxygen for at least 16 to 18 hours a day. However, in IPF or ILD, there are no large trials of oxygen as in COPD, but by consensus, we use the same recommendations. And we must remember that pulmonary vasoactive medications have been proven to be useful only in pulmonary artery hypertension and not in most other forms, most other groups of pulmonary hypertension. And it's suggested that they could be potentially dangerous because they could worsen the VQ mismatch. And interestingly, inhaled vasodilators get deposited only in better ventilated areas and they may actually improve the VQ mismatch. And that's something that the INSPIRE study recently brought about.
Sorry to interrupt, sir. Can you wind up? Your time is up.
I've got about 3 or 4 more slides. I'll quickly wind up. So what we look for really is out of proportion pulmonary hypertension. And how do we do that? We think it may be either due to an overlap of 2 common conditions or a double hit hypothesis. But I'll skip that and come to the decision-making tree. So we suspect the pulmonary hypertension from symptoms supported with an echo, confirm if needed by right heart cath, and stratify it, whether it's group 1 or group 3, which is really going to be the focus of my next couple of slides. If the lung disease is limited, the FEV1 is greater than 60%, the FVC is greater than, or the FVC is greater than 70%, or the CT shows you minimal changes, then you're more likely to be dealing with group 1 pulmonary hypertension, and it makes sense to treat it as group 1 with referral to a center experienced in the management of pulmonary hypertension. However, those with an FEV1 less than 60% or an FVC less than 70% in lung disease and extensive CT changes will be treated as group 3 pulmonary hypertension, which includes oxygen, palliative care, and pulmonary rehabilitation. The evidence for treatment is mixed, and most studies have been negative, including the which was published earlier this year, and showed that both in group 3 and group 2, use of vasodilators actually worsened outcomes, even more in group 3 than in group 2. However, the INSPIRE study gave hope, and this, remember, was those who had inspired or inhaled treprostinil, and there they showed a significant improvement, not only in the 6-minute walk distance, though this just came into the overlap of the minimal clinically important difference, but this is some hope for the future. So I'll stop with a few key messages. Pulmonary hypertension in chronic lung disease is common, but is often missed. Diagnosing the cause of PH even in this group is critical to management. Patients with chronic lung disease and pulmonary hypertension, the PH may have a huge impact even at a lower pressure. Left heart disease is often the primary cause of PH even in chronic lung disease. And identifying the group with out of proportion pulmonary hypertension is extremely important for management. I'll stop at this point. Thank you very much for your patient hearing.